We have a number of learning objectives. We'd like to understand the elements of history taking, differential diagnosis, and clinical investigation that has to do with the presentation of heart disease. We'd like to be able to appreciate these issues and ground them in the appropriate socio-cultural and psychological context. We would like to, by the end of this conference, hopefully have a working knowledge of the important differential diagnosis relevant to the presentation of chest pain symptoms, as well as explore this relationship between heart disease and mental health. And hopefully by the end, we'll share some evidence-based understanding on the role and nature of cardiac risk factors as well. Our first lecture, and I will ask Dr. Adeyemi Johnson, eminent consultant interventional cardiologist, to come up and take us through the presentation of a patient with chest pain. Thank you.
Yeah. Good morning, ladies and gentlemen. My job today is to talk about, well, two topics back to back. One is evaluation of chest pain, and the other is management of acute coronary syndrome. They kind of flow together, so it's nice we're doing it this way. Don't worry, I think we'll make up all the time. I don't have enough knowledge to take up 2 hours on this topic. So when we have chest pain, the key is this: what are we looking for? All right, many of us who work in our offices every day have patients coming with chest pain, different kinds of chest pain. The important thing is to be sure you are not dealing with something dangerous, and then kind of triage the person quickly. So first thing is you want to rapidly recognize if this is true acute coronary syndrome. All right? Then the next thing is, if it is not acute coronary syndrome, what else could it be? Your job as a doctor is to, help the patient as much as you can. Now, the key is to rule out any other life-threatening conditions, such as aortic dissection, pulmonary embolism, pneumothorax, pericardial effusion, tamponade. Now, you will be surprised to know that pulmonary embolism is a lot more common than we think. So I'd like you to pay special attention to this. It is a lot more common. Reason why we don't diagnose it is we don't suspect it, and then we don't send the patients for the appropriate tests, and we end up missing these things. But please be on the lookout for pulmonary embolism. It's not part of this lecture today, but just remember, patients coming with chest pain, always ask them, have they recently traveled? Have they just come back from the US or London? Have they gone by road to Ilorin or from Abuja? These have they been stuck in redeemed traffic on the Ibadan Expressway? Quite a few of my patients, I even have one who's an auntie of mine who died from pulmonary embolism, stuck in traffic for just 3 hours. So please have this in the back of your mind when you have patients with chest pain. Then, of course, we want to minimize cost and hospitalization in patients with chest pain that is not of a serious nature. Now, in Nigeria, we don't have, health insurance is not that yet, it's not yet very mature. So when you keep the patient in hospital 2-3 days, evaluating chest pain, you are costing him a lot of money. And you might cause more chest pain too, by the time he sees the hospital bill. Okay. So what are the goals of diagnostic testing? Like this thing says, whatever diagnostic approach you use, at the end, you must either make a diagnosis or sufficiently exclude a serious or life-threatening condition. That's what we want to do. Patient walks into your office, I have chest pain. Oh. Patient walks into your office, says, I have chest pain. You need to determine quickly, is this a serious problem? Is this musculoskeletal? You need to know fairly quickly where this is going, and then triage the patient appropriately. So that's what I plan to try and help us do today. Okay. So what are the things that cause chest pain? I believe we all know them, but I'll refresh your memories. Musculoskeletal. The most common one is costochondritis, which I actually like telling the patients because it gives them a big diagnosis to go home with. In Nigeria, patients don't like going home with, don't worry, nothing is wrong. They like a diagnosis. They like to hold on to something. So costochondritis is actually nice because it's a big word. And then some of them will go and Google it up and actually say, oh, this is my doctor. He's very sharp. Other common causes, gastrointestinal, most common of which is GERD, which I have. And I had some yesterday, and my partner was worried to death. He said I should do an ECG and all these things. I said, don't worry. I've taken Gestid, and it's getting better. But GI causes are quite common. And I can tell you that it is sometimes, even for those of us who've been doing cardiology for over 30 years now, it is sometimes very difficult to differentiate GI from cardiac. It's very difficult in some patients. So you've got to take the pain seriously and work your way through it. Of course, cardiac. Psychiatric, I think we'll have a talk on that. But we all know some of our patients who are hyperhysterical, get panic attacks. They frequently come with chest pain. Pulmonary, like pulmonary embolism, and other unknown, which seems to be quite common. By the time the patient goes, you don't know what's causing the chest pain, but you know it is not serious. That's the key thing. You might not know the diagnosis, but at least you know it's not a life-threatening condition. Because I think number one cause of lawsuits in the US in emergency rooms is this category. The emergency room doctor says, don't worry, everything is fine. They send them home. Then next thing they know, the patient died from a heart attack at home. So that's something you want to avoid. You want to try and avoid it. It's not always possible, but we have to do the best we can. So first thing, cardiac or non-cardiac. So what are the cardiac causes of chest pain? Under coronary artery disease, we have angina, which is stable. We have the unstable angina, myocardial infarction, which group as the acute coronary syndromes. We have what we call coronary vasomotor disease, which is coronary vasospasm, which occurs usually in women, usually in smokers. It is not usually related to exertion, happens at rest. Now, remember this. To make a diagnosis of variant angina, to be sure about this diagnosis, you need to do an ECG with the chest pain. You need to do an ECG with the chest pain. So if you're lucky, the patient comes in with severe chest pain, they're sweating, you do the ECG, you see ST elevations, you give nitroglycerin, everything goes away quickly. You know that's not likely to be a heart attack, it's more likely to be variant angina. But if you have somebody with that, you have to admit and make sure it is not an MI. All right, before you go through everything else. But in general, I haven't seen this too many times, but I have about 5 patients now in Lagos that I know have a variant angina. And you can further make the diagnosis by doing angiography and inducing vasospasm. Now, about 20 years ago, the standard of care was you do an angiogram, you inject some drugs to cause vasospasm and see if they have vasospasm. But we've stopped doing that because 1 or 2 out of 100 will not, the vasospasm will not go away. And then they have an MI. So it was felt it is not worth putting the person at risk for an MI just to diagnose Prinzmetal's angina. That's the other name for it, Prinzmetal's variant angina. Now, myocarditis. You'll be surprised to know a lot of our patients with what we call DCM, dilated cardiomyopathy, a lot of them started out as myocarditis. A lot of them did. Thing is, when the myocarditis was happening, usually it happens in younger people, so they don't come to the hospital with chest pain. They don't think anything of the chest pain. They rub Vicks vapor rub on their chest and they go about their business. Then it's several months later, you see them with heart failure. Now, if you take a detailed history, you might find that a few weeks ago they had fever, chest pain, night sweats, and things like that. Thought it was malaria, took anti-malarials, and then what's down the line, find out it's heart failure. So myocarditis is more common than we think. Now, valvular heart disease, these are all common in our environment. Aortic stenosis, mitral stenosis, hypertrophic cardiomyopathy, they can all cause chest pain. And then, of course, the very dangerous ones, aortic dissection. It is very important to make this diagnosis early because early treatment will save lives. And of course, post-pericardiectomy just means people post open heart surgery who've had their pericardium opened. So when we're looking at this chest pain, what do we look at? Now this is a mnemonic that helps us remember pain, P-A-I-N, pain, P for pattern, A for associated features, I for initiation and improvement, and N for nature quality. Now let me start with the nature / quality part of it. I have found out that amongst our patients, our people, when they describe severe chest pain, they usually use the word sharp. They say very sharp. Don't let that confuse you, because it has messed me up a couple of times. When they say, oh, very sharp, I think, okay, this is not an MI. But in our, I'm not sure what language makes that, but a lot of people, when they say mean severe, they use the word sharp. So you have to make them further describe it. Say sharp like a knife, or sharp like a baby or somebody sitting on your chest. Then they will tell you, oh yes, like somebody sitting on my chest, very, very sharp. So just know that they don't always use the word dog or squeezing. They tend to use sharp, so don't let sharp fool you. Okay, pattern, temporal sequence. I'm not sure where to put this so it doesn't. Pattern, temporal sequence. Now all that means is, when did the pain start? Is it been there all day? Is it come and go? Is it at night? That sort of thing. Now, one of the commonest things I see in my practice is the chest pain wakes the patient up at night. Now, that's usually either Prinzmetal's angina or GERD. Usually. Doesn't mean it's not cardiac, but that's where your mind should start going when they tell you it's every night. Then you ask more questions. When do you go to bed? They tell you 11. When do you eat supper? 9, 10. Then you start thinking this is more likely to be good. And then what I usually do, after I've ruled out everything important, I give them a trial of a PPI to take before supper. And oftentimes they come back and say, the pain has gone. So you know, but before you do that, you should rule out anything cardiac or anything urgent first. Okay, what are the associated features? Now, GERD won't cause shortness of breath. It doesn't usually cause diaphoresis. It won't usually cause a cough, fever, chills. So you've got to ask this question. Any shortness of breath, any fever, any cough, any chills. Now, you might wonder why we're asking about fever. Remember, we're looking for why the person has chest pain, not necessarily only a cardiac reason. Pneumonia, bronchitis, all these things cause fever, cough, and chest pain. So we have to look for all these things while we're evaluating the patient. And of course, abdominal pain. Now, what starts the pain and what makes it improve? We all know cardiac pain is made worse by exertion, activities. And ask the patient specifically. Don't just let them bring it up, because patients won't tell you unless you drag the information out of them. Say, do you walk up the stairs? They'll say yes. But I have to stop. Why do you have to stop? Oh, I just feel tired or something. Then you start thinking this is cardiac. All right, but ask them specific questions. Find out where they live, what kind of exercise they do. Most of my patients don't exercise. But, you know, you find out, do they go to the market? Do they go to ShopRite? Do they walk up the stairs? What activity do they do that limits their activity? So you can get some idea from all of that. And if the pain is always, like one of the patients I think I will show. She came in, she was a nurse. She said, I have stomach pain. My daughter made me come to see you. I know it's not my heart, it's my stomach. I said, okay, no problem. We said, when does it happen? Anytime I walk upstairs. My stomach starts to hurt. So I start taking Gestid and all those antacids. So we put her on the treadmill and found out it was not her stomach. It's cardiac. So epigastric pain can mimic itself and make you go off the wrong path. But remember, anything up here, ask questions. Now, also remember this, women are very tricky with their own presentation. And most of the suits for chest pain misdiagnosed are usually in women. Women, for some reason, have not read the textbook. They don't necessarily have chest pain the way they're supposed to have. And you've got to be careful. One case that I remember very clearly was a headache. The woman came in with severe headache, migraine. Only reason we got to know was she was admitted for the migraine. Nothing fixed the headache. And because she was admitted, they did a routine ECG. And ECG showed she was having an infarct. All right. So always, I mean, I'm not saying everybody who comes with a headache now, you have to start worrying about their heart. But remember, women especially and diabetics don't necessarily have a classic symptom. So you've got to ask more specific questions. And I think that's just the nature of women. We all know classic angina, central chest pain, squeezing, pressure, heaviness. In Nigeria, sometimes known as sharp. But try and differentiate that sharp and ask the person, what do you mean by sharp? Now, one thing I know, if a patient tells you they have chest pain and it's going to their jaw and going to their teeth, 99% of the time it's cardiac. 99% of the cardiac. Some of them come from the dentist because they go to the dentist because of tooth pain. They get to the dentist can't find anything. Then the dentist gives them epinephrine or lidocaine and epinephrine to do some procedure. They get more severe chest pain. And that's when they find out, oh, there's a problem. Oh, I better come. Then most dentists will send them to another doctor as soon as they have that. Dentists don't fool around with chest pain. And of course, cardiac pain usually relates to the arms, jaw, neck, usually associated with shortness of breath, diaphoresis, nausea, usually, but not always. Now, some people can just come with some mild chest pain and they're having a severe heart attack. But these are the things you should look for. And anytime the person says, my pain is worse with activity, that's always a red flag that, hey, this is my heart, let's check it out. And of course, if rest relieves the pain, a clue that it's cardiac. Now, nitroglycerin. Many of us give sublingual nitroglycerin to patients with chest pain. The fact that nitro takes away the pain does not make it cardiac. Nitro also relieves esophageal spasm. So it can be GI. But if nitro relieves it, I think you have to think about cardiac till you rule out everything else. So once you give somebody nitro, the pain goes away. Just admit the person and, work him up appropriately. Okay, so after the history, we examine the patient. Now, this is a problem I have with my medical officers. It's a big problem. They don't seem to like examining patients. They will take the history and then go straight to ECG. Then you ask them, any costochondral tenderness? They will say, starts waffling. Any murmur? They start waffling. Or some of them will actually tell you none. And then you go and listen and you hear a wide open murmur and then the patient will tell you, they didn't listen to my heart. So please, let your medical officers, junior doctors, please, physical exam is very important. I know we're in a high-tech age. But even in Johns Hopkins, or which is the best hospital in England, I don't know, but even in those hospitals, they examine their patients. Because if you don't examine, you will miss some things and you will do unnecessary tests. So generally, vital signs, general appearance. And just yesterday, I had a patient. That's why I'm remembering all of this. I had a patient come in. His blood pressure was 80. He had chest pain, shortness of breath. He was sweating. Medical officers came and told me, well, there's this man, he's on a wheelchair because he fell down. He's had some mild chest pain, think he's musculoskeletal and all that. And I was almost saying, okay, let's just do this and this. Then I saw the guy in the wheelchair. I saw him sweating. I said, so when did you fall down? He said, oh, no, that was 2 days ago that I just hurt my something. We checked his blood pressure, 80. I said, have you checked his blood pressure? They said, no, they were going to check it. These things. So just remember, we can take things for granted based on a very little bit of information, but don't let the young doctors lead you astray. Make sure they examine this patient. Simple things like blood pressure. This man had blood pressure of 80. He was in pulmonary edema. He's had bypass surgery in Italy and all those type of things. But these are the kind of things you miss if you don't examine the patient. Okay. Now we say carotids and JVP. I can tell you, majority of us do not evaluate the carotids when we examine our patients. Majority of us. I used to be one of them, but I have been burnt a couple of times. When you examine the patient, feel the carotids and listen. Listen with the bell of the stethoscope. If you hear a bruit, that means they have atherosclerosis. And then that now ups your attention level, ups your radar to saying this man might have coronary artery disease, because if you've got carotid artery disease, it's better than 60% chance you have it in your heart. JVP will let you know if the person is in failure. Lungs, listen to the lungs. That's where you pick up things like pneumothorax, pneumonia. Cardiac exam. That's standard, I believe. We listen to the heart sounds. Now, many of us can't tell whether there's a split S2, P2, P1, all those sort of things. That's okay. But listen, you will hear if there's a loud murmur or not, if there's a friction rub. All right? Or if you hear something you're not really sure what it is, then you can ask for more tests. And then examine the chest wall. Most patients with costochondritis or musculoskeletal pain, if you go from rib to rib on each side, pressing quite firmly, you will elicit some pain. And then you know, okay, I'm most likely dealing with a musculoskeletal thing. But you have to really press and go around the rib cage. Always do an abdominal exam. You can pick up things that might be causing problems. You can pick up abdominal tenderness. You can pick up enlarged liver and things like that. Another thing that is not commonly done but should be done is feeling the pulses. Every patient who comes in for a physical exam for any reason should have their pulses checked. You check, you check the apical beat, you check the radial pulses, you check femoral, and check the pulses in the feet. If you have reduced pulses, then it is likely you have vascular disease, and then that's also likely you have a coronary artery disease. So please check the pulses. And of course the skin. If the person is cyanotic, you know this is a problem. Okay, so what tests do we order? Now, everybody who comes in with chest pain should, most people with chest pain should have an ECG. Now, I know not everywhere, every facility has ECG available, but I think any adult who comes in with chest pain should have an ECG. So if you don't have an ECG machine, send them to somewhere to get an ECG done. Now, chest x-ray should also be done, but you don't have to do a chest x-ray on everybody. It depends on the clinical findings. But ECG, chest x-ray are quite important tools. Of course, you want to do blood tests. Full blood count, cardiac enzyme, liver function, amylase, lipase. You're looking for things like pancreatitis that can confuse you. Then, if indicated, things like echocardiogram, CT scan, nuclear stress test, which we can't do here yet. In general, acute coronary syndrome. The person will come in with severe chest pain. Usually lasts for more than 20 to 30 minutes. Now, the pain could be anywhere. It could be right, it could be left. Do not get confused by right-sided chest pain. It doesn't always mean it's not cardiac. Anything in the chest, take it seriously till you find out. All right? It radiates to the arms, shortness of breath, like we went over before. Now, some patients are atypical. Some will come back with syncope. Some patients will have DKA. Patient we just discharged from our ward about a week ago. Her first sign was a stroke. And that happened. She had an MI preceding the stroke. She didn't know. Silent MI. She was diabetic. She developed an apical thrombus in the LV. Through clot to her head. Had a stroke. And then while she was being evaluated, echo and all those things found out that, oh, she's had an MI. So in diabetics and women, be careful. DKA, diabetic ketoacidosis. If you have a patient with DKA, always find out why did this patient go into DKA. Patients don't just go into DKA for no reason. There's usually a precipitating factor, and oftentimes it's sepsis, oftentimes it's myocardial ischemia. But investigate. Okay, so we say ECG. What do you expect to find? I think there's a couple of talks on ECG, but what do you expect to find in ECG? Well, in this case, acute coronary syndrome, like I said, is either unstable angina or it is acute myocardial infarction. Now, in this case, you can see the ECG tracing here. If you look, you'll see ST elevations in leads 2, lead 3, AVF. Those are the inferior leads. That tells you this is an inferior wall infarction. All right, in this case, 2, 3, AVF. All right, and then you have ST depressions in the lateral leads, which are called reciprocal changes. Now, I know everybody's not going to be an expert on ECGs, but I can tell you this. These days, I tell everybody, if you do an ECG, you're not sure what's going on the patient, you're not an expert on ECG, you don't want to miss something important. These days, there's high tech in Lagos. You can use BB. You can ask if you don't have a camera on your iPhone, I bet you on your phone, I bet you some of your junior doctors or nurses have cameras on their phone. Do the ECG, take a picture. Send it to somebody who can look at ECG for you. It doesn't take much time. And most of us in cardiology, we receive ECGs from our colleagues like that. And I don't think we're going to charge. I don't think any of us will charge for that service, but I think it's something you should do. You have a confusing ECG, send it to a cardiologist or somebody who's comfortable with ECGs. And you can do it by BB, you can do it by the phone, and then what's that one they do now? WhatsApp and all these other things. There are many ways of sending these ECGs. If you can't do it, ask your junior doctors. They can do it. That's one thing they know how to do. All right. This is another acute MI. You can see peaked T waves in the anterior leads, and then the ST elevations. This is a very early myocardial infarction. This is the kind of one, if he comes to the hospital and is treated within an hour, they will have virtually no damage. So that's the key in the next presentation. Speed, speed, speed. Very important. Your evaluation for an acute coronary syndrome patient should take less than 30 minutes. And a decision made and treatment started. But AHA guidelines for ST segment elevation, remember, once you're thinking acute coronary syndrome, whatever is on your mind, even if you're not sure if it's GI, if you think the man might have an ulcer, give aspirin. Give 300 milligrams of aspirin or 325, depending on which version you have, American or British. But give aspirin, very important. Antithrombin, give, if you have clopidogrel, give clopidogrel. So at least you're doing something while you're evaluating the patient. All right, so what I usually do, somebody calls me, doc, I'm having chest pain. I say, take aspirin. Almost everybody has aspirin at home. Take 300 milligrams of aspirin, that's 4 baby aspirin, and start coming to the hospital. Now, if it's within 12 hours of pain, then they're eligible for lytic therapy or angioplasty. If it's after 12 hours, the damage is already done, so now you're trying to just salvage things. You don't need to give lytic therapy. The reason you don't give lytic therapy after 12 hours is the risk of a complication from the lytic is much more than the benefit you're going to give the patient. So, but there's some gray areas. Now, if the patient says, my chest pain started last night, and this is, no, started 2 days ago. Now you might say, okay, this is over 24 hours. But it tells you, but it got worse this morning. That's why I came. Then you can assume the pain, the ischemia is still ongoing, it is still active. You don't have to go by when it first started. It's when they last had chest pain. All right, so if somebody had pain 2 days ago, been on and off, and then he comes in with more severe pain, he is still a candidate for lytic therapy because the severe pain started just before he got to you. All right, let's go through this. This looks a little bit busy, but I think you will understand this when we go over it. Now, definite acute coronary syndrome. Now, you've got your symptoms, all right? You've got the patient. He's having chest pain. He's sweating. He's short of breath. He just doesn't look good. You're pretty sure something bad is happening. So you put him in this category. Okay, this is a definite acute coronary syndrome. All right? You do an ECG. Any ST elevation in the ECG. If there's no ST elevation in the ECG, then you start looking at other things. Okay, what's going on? And I can tell you that this is going to be the most common part where the ECG is not going to be diagnostic. All right? Most of our acute coronary syndromes, ECG is not diagnostic. So you've got to be pretty alert not to send somebody home with acute coronary syndrome. Now, but look at the ECG. It's usually not completely normal. You look at the ST segments, T-wave inversions, you will see some subtle T-wave changes, ST depressions. And then if you are lucky, you have an old ECG to compare with and you see some changes. Then you can say this is definitely acute coronary syndrome. All right? But these patients do not qualify for thrombolytic therapy. They don't qualify at all. So you don't give. But you give other things. But we'll go over that next slide. But next topic. But once you have this, then you start thinking. If you are where there's a cath lab or near a cath lab, you send the patient there and they can do an angiogram and find out for sure what's going on. If there's no cath lab, then you move over here to where it's possible. You repeat the ECG. All right? Don't send the person home. If you're not sure if this is cardiac or not, please don't send that person home. Because you'll find out the hard way that something has happened to them at home. So ECG is normal. Okay, you do your cardiac enzymes. Troponin, CPK, MB. Those are the important ones. It doesn't matter if it's troponin I or troponin T. Any troponin you have available is useful. Now, I've found out that some of us don't have access to troponin, and we send them out to a lab, and then the troponin comes back the next day. That's not useful. You need your troponin back early. And the kits to check troponin are not very expensive. We can get them. Now, you keep the patient in your hospital and observe. Repeat the ECG and the cardiac enzymes in 4 to 8 hours, usually 6. Now, the second set of enzymes is negative. Then at least you're rest assured he is not having a myocardial infarction. All right, then you can take your time. But if the enzymes are positive, then you assume, okay, he's had a small infarct, non-ST elevation MI, and then you treat accordingly. Now, most patients will come over to this place. You repeat the ECG, it's normal. You repeat the cardiac enzymes, it's normal. You say, all right, after 6 hours, then usually patient comes in 10 in the morning. You repeat all this stuff at 4. You get all your results back by about 6. And I usually end up keeping the patient overnight. And then the next day, we decide, okay, everything else is normal. No damage has been done. Let's do a stress test. All right? And then the stress test will help tell you if the man has coronary artery disease or not. Now, never send somebody with active chest pain for a stress test. It just is too dangerous. It's happened to me as a young cardiology fellow. I did a stress test on a patient, and I remember the patient came in about 6. The office was closing. He had chest pain. I said, this is not likely to be anything. I took him to the treadmill. I said, let me just do a stress test on him. This was in the US. I put him on the treadmill. He was watching the ECG himself. Then he just said, Doc, what are all those squiggly lines? He went into VFib and then went down. We had to shock him. Anyway, within an hour, he was in the operating room, had open heart surgery, had left main. But I learned not to do the shortcut that day. Because you're thinking, I'm supposed to go home. Let me just quickly do this and go. I almost killed that man. So I know now, if you have any suspicion this is acute, if it's cardiac, don't do a stress test that day. Wait till everything is stable. And then you do the stress test. And that's one other thing. Because of this experience and some other experiences, it is important when you do your stress test, make sure it is somewhere where there's a defibrillator. Because 1 or 2 patients you don't suspect will go into VFib or VTAC. And it will be very sad if they actually die on the treadmill. So always have a defibrillator handy. Even if it's not the regular type, the AED, just have it handy. You'll be surprised 1 or 2 out of about 10,000, but it's that 1 or 2 that will cause you a lot of grief. And so you don't want to kill an innocent man. Just make sure you have a defibrillator around. All right. Now, stress test is abnormal, then they go into the invasive strategy. All right. Now, if they have ST elevations, we shall go, that's treatment of an acute myocardial infarction. We'll go over that shortly. Okay, I hope this shows. Now, once again, these are ECG changes, what you see in acute coronary syndrome. If you see this, these deep symmetric T waves, be very afraid. This is a bad ECG. You know, there's no ST elevations, there's nothing like that, but they're deep T wave inversions. Just know that you are dealing with a hot potato. This is a seriously ill person. Except, of course, in us Nigerians, black people. You can have some people with LVH who have this. But you know, until you know that's what the case is, you treat this as an acute coronary syndrome till you find out that this is the person's standard ECG. All right. In fact, when I was in the US, the most common reason I got called to the emergency room was acute heart attack in a black man. And you find out this is just J-point repolarization that we all have. But when you're in a white environment, they look at it as a serious problem. But in general, you see this kind of ECG, take it very seriously. And this is the cardiogram of the person with this ECG here. This is called the left main. This is the left anterior descending artery. This narrow in here is about 90%. So this is a 90% stenosis of the left anterior descending. All right, this is another ECG. Now if you look here, does anybody see anything abnormal in this ECG? Nobody wants to hazard a guess, opinion? Okay. I can tell you how this ECG evolved. This is the patient's ECG without chest pain. All right? This is the follow-up ECG with chest pain. Look at leads 2 and lead 3. Look at them here. Look at there's ST depressions here. Look at lead AVF. There's ST depressions here, which were not there when the patient did not have chest pain. Can you see it clearly there? All right. So these are the subtle things you look for. All right. That's why you should do an ECG with chest pain. It makes life simple. If you can catch the chest pain and you get ST changes, then you got your diagnosis and you take the appropriate treatment. And you look here, some minor ST depressions here as well. All right. When you look at this, this is the inferior wall. I hope I've got this slide correct so I don't tell a lie. But this is most likely ischemia in the right coronary artery. So let's see. Yes, okay. So this is right coronary artery, and this is a subtotal occlusion of right coronary artery. So reason why this was not an infarct is there's still a little bit of flow. It's 99.9% occluded, but there's still a little bit of flow. And when it goes into spasm, the ST depressions come. So that's what it looks like. So if you can get the ECG during chest pain, it is a big deal. It's a big deal. It helps you a lot. Okay, what cardiac enzymes do we do? Now, we all know the different kinds of enzymes. I won't waste your time by going through every one in detail, but I will tell you, myoglobin is not useful. Troponin T, troponin I are both very useful. CPK. Now, remember, when you do your CPK, do CPK-MB, not just CPK. Routine CPK will go up for any reason. Somebody hits you in the chest. Intramuscular injections. That's one thing in cardiology. We don't give intramuscular injections until you've ruled out what's going on because they can raise your enzymes. But you want the CKMB. You don't want the myoglobin. You don't want total CK. You just want CKMB. Now, some people also do LDH and all those things. They're not very useful. They're not very useful. What you want is this, this, or this. Anyone, troponin I, troponin T, it doesn't matter. Anyone you have, just get it. Now, when are they useful? Myoglobin comes up first. All right? Within a couple of hours, myoglobin is up. All right? And it comes down rapidly. Within 24 hours, it's gone. But many things make your myoglobin go up. So it's not a very specific or sensitive test. That's why we don't use it. Now, your CKMB goes up here. All right? And then starts to come down this way. Your troponins stay up for about 15 days. All right, this is normal level here. Troponin I, troponin T both stay out for at least 10 days. All right. So if the person comes in that, doc, 3 days ago I had severe chest pain. It's gone now. You can still do a troponin. If troponin is negative, you know they did not have an infarct 3 days ago. Doesn't mean it's not cardiac, but you know they did not have an infarct at that time. So troponin is the most useful test, but it is not a gold standard. There's no gold standard in all these tests. All of them give you false positives. But once you have a positive troponin, you have to take action and treat as ischemia until proven otherwise. Okay. Now, the importance of chest pain. Of chest x-rays. I know we're in high tech. We have cardiac catheterization. We have echocardiogram. We have CT angio. But chest x-ray is still a basic, very important part of evaluation of these people. Now, let me see if I have any ideas as to what this is. This is a 70-year-old man following CABG. That's bypass surgery. He developed acute dyspnea and right-sided chest pain after waking up. On exam, he was tachypnic. He was hypoxemic. This is the x-ray. I don't know if that light is... Can you see the x-ray clearly? A bit? Okay. Well, let me tell you. This is a catheter. all right, in the pulmonary artery. This is what's called a swan gas catheter that's used commonly after surgery. So this is not a problem. The heart size is pretty much normal. The lung fields are clear. All right, so essentially this is a normal X-ray. So what comes to mind? Any ideas? Any suggestions? Everybody's quiet. Nobody wants to commit themselves. Okay, you remember what I talked about at the beginning? Have a high threshold of suspicion for pulmonary embolism. All right, have a high threshold of suspicion. Anybody post any kind of surgery, has chest pain, shortness of breath, any kind of surgery, even appendectomy, think of pulmonary embolism. It is #1 cause of preventable deaths in hospitals. #1 cause. So this is in a cardiac unit. And he had pulmonary embolism. And it is not uncommon because after open heart surgery, they're in bed. They can't get Clexane. They can't get anticoagulant therapy. So they're at risk. That is why these days, as soon as they have surgery, they get them out of bed in 24, 48 hours. 24, 48 hours. I always remember my dad when he had his own open heart surgery. He had his surgery while I was working. And then the next day I went to visit him. He called me and said, Yemi, I beg, tell those nurses, oh, they don't know that I've just had open heart surgery. They're telling me to walk, that they should come back next week. I said, Daddy, they know that you're in their units. They know you had surgery, but they don't want you to get sick. So, you know, they get them up very quickly, very, very quickly, within 24 hours. I mean, after 24, 48 hours, they're out of bed. No matter how sick they are, they will get them out of bed, unless they're still on the ventilator. Then that's a different thing. Then they'll give Clexane and things like that. But they're out of bed quickly. Because in somebody who's had open heart surgery, they have a massive pulmonary embolism. Your treatment options are very limited. You can't give him lytic therapy because he will bleed to death. You can't start taking him back to the operating room to do a thrombectomy because mortality rate is above 50%. So the best treatment is for it not to happen at all. Not happen. Or if it happens, then the next treatment is prayer. And just pray very hard and hope nothing else happens. Okay, this is a perfusion scan. Now, we don't do this anymore. And we don't do it in Nigeria. I hear we don't have nuclear facilities in Nigeria because they're not sure we can regulate ourselves. So we don't have access to these things. But this is a perfusion scan. This is what it looks like. A perfusion scan means they inject a radioactive material into your vein. It goes to where blood flows, so it goes to the pulmonary arteries, it perfuses the lungs. They take a picture of the lungs, and you should see the lung fill up with white, evenly. So in this place, you can see this place doesn't fill up. This place doesn't fill up. This doesn't fill up. This doesn't fill up. So this is what we call a perfusion defect. So that shows there's obstruction to the blood flow of the lungs. That's pulmonary embolism, most likely. Okay, so this is another X-ray. 49-year-old man, hypertensive, sudden mid-back pain, shortness of breath, unrelieved by change of position, radiation to the left chest. Anybody see anything on this X-ray? There are two things on this X-ray you should see. Heart is enlarged, good. Okay, there's widening of the mediastinum here. Okay, so man has heart failure. He has enlarged heart, and then he has a widened mediastinum. When you say widened mediastinum in somebody with chest pain, just know you and the patient are in for a long day. His own day might be shorter because it's usually aortic dissection. And right now, at least in Lagos, if you have an aortic dissection, thoracic aortic dissection, you're in trouble. We can't treat it. We can't treat it yet. I had my cousin, I took him to the emergency room in Lasut. He had I was at a meeting somewhere here. They called me to the hospital, took me to the airport. He was coming off a plane, severe chest pain. As soon as I saw him, I knew there was a problem. I said, I hope this is a heart attack. And we were saying, why are you hoping it's a heart attack? I said, if it's aortic dissection, we have no treatment. And true enough, we went to Lasut emergency room, did ECG, chest X-ray, wide mediastinum. Blood pressure was 200. We couldn't do anything about it. Within about 3 hours, he was dead. The only treatment is surgery. Open heart surgery, and we just don't have it yet, but soon coming. Soon coming. So this is a CT scan. At least we have this. We can diagnose it now. But still, aortic dissection, actually, let me not say you can't do anything. That's not exactly true. You can do some things to buy time. Not all of them die immediately. You can do some things. Usually the blood pressure is high. Bring down the blood pressure. Bring down the blood pressure. Don't give anticoagulation. Just bring down the blood pressure. Use beta blockers. Use nitroglycerin. Use anything you've got to bring down the blood pressure and drop the heart rate. All right, this is a CT angiogram. This is the aorta. And this dark part here is the dissection. This is what's called the false lumen. So if you suspect aortic dissection, just send them to the CT scan. Tell radiologists they're looking for aortic dissection. They know what protocol to use, and they can get you this picture. Even us non-radiologists can see that this is not normal. There's double lumen here. But typically, you need radiologists to look at it because CT scans are not that simple to interpret. And this just shows you classification of different types, type A and type B. Type B means distal to the left subclavian. This is left subclavian here. Type B, you can usually manage medically. 80% of them can be managed medically. Only a few need to go for surgery. But type 1 and type 2, which are all type A, usually need surgery. This is the worst type, from proximal all the way down. All right? Which also brings me back to physical exam. One of the things you should do in physical exam in somebody with chest pain is take the blood pressure in both arms. If you get a differential blood pressure, you start thinking there might be a dissection. All right? If you feel the pulses and you feel you don't have good peripheral pulses, but the pressure is 200 up there, you can check the pressure in the leg. If it's low, it might mean a dissection as well. So those are clues. Okay, this one is easy. 18-year-old kid, high school wrestler. I think they've banned wrestling in the Olympics now. But high school wrestler, right-sided chest pain. Reduced breath sounds on the right. Anybody see anything? Look here. Compare here to here. Yes, darker. There are no long markings. Yes. So it's most consistent with pneumothorax. So treatment is very different from acute coronary syndrome. If you give this man TPA, I don't think the results will be very good. Okay, this is another common finding. 45-year-old alcoholic man with fever, chills. Productive cough over 2 days. I think we can see this here. There's an infiltrate there. So please, again, do not discount the use of X-ray. We're in a high-tech world, but basic things are still very important. So history, physical exam, ECG, X-ray. We all have access to these technologies. Now, cardiac catheterization and stuff, that's a different level. But most of our patients can be diagnosed with these things. Okay. Now, this is a prelude to acute coronary syndrome. All acute coronary syndromes are part of the same spectrum of disease. This is your endothelial lining. This is cholesterol buildup. This is all the designer stew, roundabouts, of father stew, all those things. This is where they go. All right, so, and then something breaks down the endothelium here. Usually stress, smoking. Something breaks down the endothelium, and then tissue factor is released from this lipid core out there. It attracts platelets, then blood clots form, and then you have an occluded vessel. Now, the difference between a myocardial infarction and unstable angina is, in unstable angina, the blood clot does not occlude the entire vessel. There's still blood flowing. It will make a 70% lesion go to 99%. But there'll still be blood. In a heart attack, the whole vessel is occluded. So that's the difference. Okay. Thank you. Questions now? Okay. So any questions, please?
Have we been stunned into silence? No. Good question? The next talk is ACS. I think for me, the single most important message is the importance of history taking and the use of those very basic investigations. I mean, how many of us have direct access to cardiac catheterization? How many of us have direct access to chest x-rays, blood tests, and just the opportunity to talk to the patient? So the art of the consultation is something that we really need to begin to focus on even more.
Okay, sorry, and I have two. Okay, no, this is still part of the first lecture. Just to show you an example of a typical patient. This is a real patient. Okay, 65-year-old pastor complains of episodic chest pain. Pain is associated with tiredness, excessive sweating, and insomnia. Now, I'm showing this to show you that these patients are real. It's not textbook. These are real patients. Patient had 3 major episodes of chest pain. First in 2004, second in 2008, and the last in May 2012. All of which, for which he was hospitalized. And they made a diagnosis of angina at that time. Now he was put on all these drugs. And in spite of the drugs, he's on beta blockers, on isosorbide, aspirin, Lipitor, clopidogrel. So I can tell you, whichever doctor I saw at that time did the right thing, put him on the right drugs. But he still had chest pain. Pain got worse over the last 2 weeks. Past medical history, notable for hypertension. So we decided to do a stress echo. Now I'll tell you the reason why we did a stress echo as to regular stress test. But we did a standard Bruce protocol. He exercised for 3 minutes, which is less than 3 minutes, which is very poor. Chest pain developed during the stress test. Now, I'll show you his ECG later, so that'll explain why we did a stress echo as opposed to a stress ECG. So on exam, very worried, anxious looking. I don't know who examined him, or whether it was me or Dr. Gunyaki, but he developed chest pain while talking. Blood pressure went up to 205. Troponin times 3 was negative. So you notice we did a troponin 3 times to be sure it's safe to do a stress test. BNP, normal. Creatinine, other labs, normal. Okay, so this is his rest ECG. So you can see at baseline, he has ST depressions. All right, without chest pain. These kind of patients give you a false positive once you put them on the treadmill, because the ST segments will change and look worse, whether or not they have ischemia. So if you have this kind of ECG, if you have availability to do a stress echo, it is better. It gives you more of a diagnosis, because the baseline ECG is already abnormal and it can throw you off in the wrong direction. So we did a stress echo. This is ECG at peak stress. You can see there's not much difference. ECG at peak stress. So this wouldn't have made a diagnosis based on this. This ECG, 10 minutes in recovery. You can see now there's some changes. There's more ST depressions, there's T-wave inversions. When you see ECG changes post-recovery, 10 minutes, take it very seriously. That means there's something going on. ECG should go back to normal. But if ECG is still abnormal 10 minutes after, it's most likely ischemia. Okay, this is the part I'm not sure. Can you start it? This is the stress echo. All right. This is what we call the 4-chamber view, but this is the left ventricle. So what the echo does, you take a picture before exercise. So this is the rest echo. You see the contraction of all the walls. This is the anterior lateral wall. This is the septum. All right, you can see everything is squeezing. That's what it's supposed to do. Next one. Okay, this is another view. This is the inferior wall. This is the anterior wall. You can see both sides are squeezing normally. That's what it's supposed to do. All right. Next one, this one. This one down here. Okay, this is another view called the parasternal. This is the anterior wall. This is the inferior wall. You do several views so you don't miss any blood vessel. You can see everything is squeezing. All segments are contracting normally. And you can see this one too. This is contracting normally. Now look at this hole here. This is the left ventricular cavity. In a normal person with exercise, this hole should get smaller. That means the muscle is contracting more vigorously. All right, so let's go to the next slide. Oh, I think I can do that one here. Okay, you can start, yes. Okay, look carefully now. These are the same views side by side. I'm sure even those of you who don't do echoes, you can see a difference. Look at this wall here. Look at it here. Here it's not moving. Here it's moving vigorously. In this one too, this is all moving. You see here, the apex here is not moving. All right, this is an indication there is ischemia, and then that's what you get. You get hypokinesis or dyskinesis during the stress test. So this is textbook diagnosis of myocardial ischemia, and you can see, you can tell the blood vessel once you know your, once you know your anatomy. Okay, this one. So this is the other views. This is the anterior wall. You can see here, you look, maybe it's moving, maybe it's not moving. That's why you do several pictures. But you look at this one. You see this segment here, you see this squeezing down here, you see up here, it's not moving at all. All right, next one, please. Oh, I can do that. All right, you can play that one too. Okay, this is the picture I told you. Look at the hole in the middle. You see this? You see this diameter here is small. Look at this. It should get even smaller, but it's actually bigger. It shows the left ventricle is not contracting as vigorously as it should. All right, and you look in this view too. You see the anterior apical wall not moving. All right, and this one is moving. So this is exercise. This is rest. So this is textbook myocardial ischemia. This person had a left anterior descending artery disease. All right. Now another patient. Let me try to remember the story now. Okay. This is a patient with chest pain on minimum exertion. All right. ECG, everything at baseline did not show ischemia. He had what we call an intraventricular conduction delay, almost like a left bundle. QRS is wide, but no significant ST changes. Did a stress echo, a stress test on this gentleman. Now this is the stress test. It didn't go very far, but look at leads 2, lead AVF. You can now see ST depressions, which were not there before. Look at V5, V6, ST depressions, which were not there before. And then look at AVR. Let me go back to the resting ECG. Look here. Look at the ST segment here. It's flat. You come back here. This is actually a new finding in cardiology on ECG. If you get ST elevations in AVR during the stress test, very indicative of left main disease. So if you see that during the stress test, just stop immediately. Don't push the person because they can crash on the table, on the treadmill. You see these STs go up. Just stop. You start seeing ST depressions. All right, there's no need to push and see how far the person can go. The person has chest pain, ECG is changing, just stop. You made your diagnosis, you take it from there. Don't push and say, okay, let me see if we can do 10 minutes, because he might not come back. All right, you can see the marker there shows the ST elevation that wasn't there before. So this is textbook left main. Now, the other thing about ST changes, where the ST segment depression occurs during stress test, does not tell you where the lesion is. It just tells you there's ischemia. So you can have a left main having what looks like ischemia in the inferior wall. It doesn't tell you where, except this AVR ST elevation suggests left main. But these ST depressions, you can't figure out which vessel, but you know something is wrong. So this person had an angiogram. Well, the echo is here. You can play it. Echo was normal. So you see, you can have severe coronary artery disease with a normal echo, normal ECG. So don't let those normal things fool you. Always listen to the history. I have chest pain anytime I walk. I have chest pain anytime I have sex. Anytime I take my shower. The last person we did the stenting last week, it was shower. Anytime he had his shower, he had chest pain. His wife had to take his bath for him. So those kind of things, you take it seriously. His echo is normal, ECG normal, but stress test is very abnormal. And this is the angiogram. Now you see here, This is what's called, this is the left, this is the catheter. We go from the groin. The catheter comes into the aorta. This is the right coronary artery, which is normal, but this is the left main here. You can see right at the end there, you can see it narrowing there. All right, and there's some LAD disease. I don't know if you saw that, but it should loop and come back right here. There's only one treatment for this. Well, there's more than one treatment, but the man, you need surgery. And this person went to India and had surgery. Hopefully we'll be doing this surgery in Nigeria this year, according to the plans of Lagos State government. We should be doing this very soon. Okay, then I have another one to show you. Just live cases or real cases. Yeah.
The ECG is a very important tool for us in primary care, but there seems to be here a poor R-wave progression, which is something I would have thought was a bit of a giveaway.
Yeah, the poor R-wave progression is, let's go back to the rest. Okay, it's here. There's poor R-wave progression, all right, but this is most likely due to his interventricular conduction delay, all right? There are no Q waves. There's a little bit of an R. So usually that means there's no infarct. So, but it's abnormal, but not necessarily ischemia. It might be a conduction defect or something else, but not necessarily ischemia. Okay. All right, let's come out of that. We'll go to the beginning. What's the person who came in? Chest pain, CST elevations, anterior leads. This is an anterior MI. This is a clot in the left ventricle. This is the echo. This is the angiogram. This shows an occluded LAD here. This part is occluded. Angioplasty was done. This is the angioplasty balloon. And you can see the vessel is now open. Can you play it again? So, ECG, ST elevations, anterior leads, echo, clot in the left ventricle. These are the ones that get strokes. Occluded vessel here. You can see that here. It's supposed to go all the way down this way. Angioplasty done, balloon, this is the wire, and this is it after. So that's what, these are all real cases. So those of us who think we don't have ischemic heart disease in Nigeria, please, we do. And these cases are all in the past 6 months. So there's nothing ancient about this. This new lifestyle of not walking anywhere, going to Mr. Biggs or Father Stew, all these things, while going and all these things, that is what's happening to us. Thank you.
Thank you very much to Dr. Adeyemi Johnson, again, for a most insightful presentation.